Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In this episode, we hear from Dr. Rebekah Fenton and Dr. Sharon Humiston as they share their expert insights on strategies to achieve health equity when offering HPV vaccinations to eligible patients. They also answer frequently asked questions about HPV. Dr. Rebekah Fenton is an adolescent medicine physician, and Dr. Sharon Humiston is the Director of Research at Immunize.org and Associate Editor of IZ Express. For more information on them, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what our experts have to say.
So now we just wanted to focus on some of the groups that we thought may get missed when we look at the data of who is reflected in getting the vaccine. And yet we know, as we've already discussed, how this is really truly beneficial for everybody, regardless of gender, area, sexual orientation, and just wanted to kind of show that within certain groups. So first, I want to talk about our young adults assigned male at birth. So when we look at the HPV vaccination among males, we find that good news is between 2016 and 22, we have made some progress. We went from 37.5% to 60.6%. We still see, even initially and continue today, although we're starting to close that gap, that those who are birth-assigned females are still vaccinating at higher rates. And so then we think about some of the factors. We talked about this a little bit, that, hey, first, we really got the message out there, this vaccine's important. It's for cervical cancer, it's for girls. And then 2011, we're like, oh, it's for boys too. And that there's still some catch-up that we're doing from that message. That also those recommendations have changed as far as initially thinking that it only was through the age of 21. And so there was a lot of missed people, as opposed to now the strong recommendation for it being up to 26. And then we think about some of the things that have hopefully helped us and continue to help us. And I think the biggest thing you're going to hear me repeat constantly is that healthcare provider recommendations. And I think you are those providers that are strongly recommending it, but also sharing that with your colleagues who maybe aren't necessarily so excited about being the HPV champion, to know that even just recommending this as a part of their routine practice really does have a huge impact on helping patients get vaccinated, as well as, again, those frequent contact with their healthcare provider. So HPV vaccination and infection awareness among gay and bisexual men. Basically, they asked, like, are you even just aware that HPV as a virus exists? And then a separate question, are you aware of the HPV vaccination? And I think what for me was really surprising is to see that the overall awareness is improving for both, but yet people are more aware of the HPV virus as opposed to the vaccine. And so great that the awareness of, hey, this is a sexually transmitted infection that could potentially cause problems. But if we're not as aware of the treatment as we are as the problem, then certainly there's a gap that we need to fill between those two. And then when we think about coverage among men who have sex with men and the transgender women, so essentially there was a study that looked at the self-reported HPV vaccination status of about 1,400 participants within that age group of 18 to 26 in various metropolitan areas. And again, the study was done in 2016 to 2018. We found that actually barely more than 1 in 5 had actually completed that vaccination series. And that actually their first age that they received it was at 19, which we've all acknowledged is way later than what we would recommend, especially since 73% of them had actually reported having their first sexual contact. And as we said, one encounter is all that it may take to be able to have contact with a virus, that many of them had contact long before they were ever vaccinated or received that protection. But then again, on the other side of what helped them get that vaccine was, again, those potentially missed opportunities of, yes, they unfortunately were missed in childhood, but somebody at that age of 19 was like, hey, I think this is a vaccination that would really benefit your health, and that they agreed to that, as well as there were kind of some other minor things that helped, such as the communication we heard in other studies, like mobile apps, web apps, as well as text-based reminders and education. And now moving on to women who have sex with women. So another survey is 2019, about 500 women who had sex with women in the ages of 18 to 45. And we see a huge discrepancy, similar to some of the data we saw earlier on, as far as when these things were recommended, and therefore when people got appropriate coverage, that within the 18 to 26 age group, we have 65% of them did get HPV vaccination versus 27 to 45. That's only 1 in 3. And again, huge driver for vaccination was that healthcare provider recommendation, as well as part of that, having disclosed their sexual orientation to their provider, helped them realize, okay, this is something that, regardless of who your partners are, again, with that intimate contact, they are at risk, as well as greater perceived social support for vaccination. So people in their lives think like, yeah, that's a really good thing for you to get protected for, especially these are the age groups where they're often starting to think about that cervical cancer screening and pap smears. And so when you're putting those two things together, like, hey, this is what we're testing for, this is our opportunity to protect you from that concern, that helps us be able to more effectively get that message across. And then we think about our adolescents who are living in rural communities. So the 2022 National Immunization Survey found that basically they kind of compared metropolitan areas to kind of outside of metropolitan areas to our non-metropolitan areas, which includes rural communities. And while the data was kind of complicated, up to 11.5 lower percentages of vaccine coverage in those rural areas compared to the metropolitan areas. So they also were less likely to have a well child, which we know was a missed opportunity for them to even receive that vaccine. And that was as a main driver for those differences. We also see that healthcare providers in rural areas may be less likely to recommend HPV vaccination, as well as in rural areas and southern states. Adolescents and caregivers themselves are reporting greater barriers to receiving vaccines, such as lower confidence in them, especially with the routine vaccines, as well as in the post-still COVID world, and a lot of the misinformation that's come from science, and particularly vaccines, as well as continued expression of some of those concerns with safety and ingredients in the vaccines. So the same tools that help us be able to increase vaccinations in rural communities are often going to cover everything else that we talked about, encouraging attendance at those 11 and 12-year-old visits, making sure that we're sharing effective vaccine recommendations, understanding some of those parent guardian concerns. We talked about that that's really just inviting the opportunity to even discuss them by asking that question, addressing those concerns. And I love that we talked about the fact tennis. There actually are some studies just even realizing, I think often in the midst of COVID, we were like, oh, these really cool posters are saying, here are the myths that people are hearing and here are the answers. And what I find fascinating is that when they actually shared these posters that we all as providers were like, yeah, that was really great. We really answered all of those. In the end, after seeing them, the families and patients themselves left just reinforcing their own beliefs because they saw them printed on the paper. So really avoiding answering back, repeating any of the myths that you've heard, but instead only responding, as we talked about that one sentence that she mentioned, with the fact that responds to that belief without repeating it back, and then ensuring that we're having consistent messaging on the importance of vaccination. And I loved how you expressed that being across the entire healthcare team, not just coming from the provider themselves, so that they're getting multiple reinforcements even just in that one visit. And so then in summary, HPV vaccination barriers are frequent, numerous, and can vary by patient population. But again, the biggest thing across all of these groups is when we are not recommending the vaccine, then we are losing that opportunity for patients to understand that this is something that we value just as much as the rest of their healthcare, as well as a lack of knowledge about the vaccine. And that's also our opportunity to be able to provide that education, perception that somebody is too old for the vaccine or that it's unnecessary, as well as safety concerns. And yet understanding these barriers allows us to be able to have targeted approaches that often look very similar in nature, but maybe different in design, such as those effective recommendations, providing patient education and addressing all of their questions, as well as improving attendance. And so ultimately, HPV vaccine education and recommendations provided by us as healthcare providers are key for improving their uptake. And next, I just wanted to talk a little bit about some of the coverage inequities that we notice. I will say that I practice in a federally qualified health center where the majority of my patients are Hispanic. And so I'm always kind of curious about like, where are we missing patients? And so I actually looked into this thinking like, oh, it was for sure going to be Black or brown kids because we feel like that's often the answer, unfortunately, with all of these inequities. And so I actually was quite surprised when I looked into this teen vax data to find that actually, at least within these most recent years of 2018 to 2022, that it was actually white youth who had the lowest rates. But I would say statistically, very little difference. And so generally, there's a lot of work to do for all of our groups, seeing as the maximum that we're seeing is not even 61%. And then this one, I think, is the bigger effort that I'm hopefully, as far as thinking about inequities that we all take away from today. So they actually divided this data into 4 groups, but I figured we could focus just on our uninsured, private insurance, and any Medicaid. And there was kind of a 4th group that was a catch-all for kids who were like, for example, military insurance or other forms of insurance. You know, again, often the answer is like, oh, Medicaid, they can't. But the reality is, thankfully, it's covering their appointments, it's covering their vaccines. And so they actually have the highest rate as opposed to private insurance. And yet for uninsured patients who have the same access to vaccines, they are significantly less vaccinated. And I think a big part of that has to do with, of course, their inability to access healthcare generally, or the barriers that they have to experience as a result of that, or some of the additional costs that we often add to visits, even if the vaccines themselves are free. So I imagine all of us are very familiar with the Vaccines for Children program, or VFC for short, and certainly that has given us the ability to be able to make up for some of the inequities that we just saw on that last slide, but that allows us to cover the cost of vaccines for all of those who are eligible, and that is anyone under 19 who is uninsured, underinsured, Medicaid eligible or enrolled, as well as our American Indian and Alaska Native patients. And CDC purchases vaccines at a lower cost that can then be distributed to our clinics. And it was interesting to note that actually in 2020 to 2022, the rates of orders for HPV vaccines have declined. And I think I'm curious, but didn't really find some information as to like why, but certainly demonstrates that we're getting less of these out to patients, which is the exact opposite that we're hoping to achieve. So final takeaways, HPV vaccination is prevalent in both males and females. If the HPV infection persists, can lead to many types of oropharyngeal as well as genital urinary cancers. Effective approaches to increasing HPV vaccine include strategic messaging, such as the presumptive approach, or really the focus on cancer prevention, as well as maintaining open lines of communication across visits. And then we need to find ways to optimize our coverage for U.S. adolescents, especially those who are underserved populations, referring to our males, LGBTQ, to make sure that anybody, regardless of gender and sexuality, is being covered, as well as meeting the needs of our underserved patients with insurance as well. And that barriers should be identified and that we're mitigating those in a patient-centered approach and acknowledging that every environment is so unique. So I just find even within my clinic setting, I am constantly adapting my messaging based off of the feedback that I'm getting. And so really approaching all of this with an approach of cultural humility and knowing that communities themselves will tell us their concerns and we have to adapt to be able to address those as opposed to bringing our preconceived notions. We have tried vaccinating men who have sex with men who are HIV positive up to 45. Unfortunately, the insurance does not pay for it, even with 340B pricing. Any additional resources to consider?
I would say talk to your state immunization program because sometimes there's state money that can be used for adult vaccination, but that varies very much from state to state. So that would be my first inclination, is to talk to your state program.
Agreed. At least I know for Illinois, we have a program that does cover the vaccine for patients who are uninsured, and that's been hugely helpful for making sure that we're reaching any population that does not have access through their insurance. Next question, can we use the vaccine for a child with recurrent cutaneous facial warts?
No, we said that there's 200 different kinds of HPV types, and the cutaneous warts are different than the mucosal warts. So no, the answer is no, there is no vaccine for that.
Next, what is the downside of giving a 23-year-old male the vaccine, even if he has had sex in the past? There is no downside. I think it's just being realistic about the benefits being potentially different than prior to exposure. We, of course, as we said, there is greater than 200 subtypes. We're not doing routine testing in that person, so we don't know what subtypes they have been exposed to, but our goal is to protect them from any of the subtypes that they may be exposed to in the future, and that's the reason why we're still continuing to offer it, in addition to, of course, preventing cancer, as we saw, better to get it later than not at all.
So I just want to say that, unfortunately, in the United States, there is no vaccines for adult program, and so an adult who isn't covered by insurance may end up being asked to pay out of pocket unless they can find an adult vaccine through their state immunization program.
There's a couple questions they had about timing for the vaccine. One was asking the recommendation for women, is it 2 or 3 doses? And I think another one was asking something that we talked about in our prep about the recommendation for 1 versus 2 vaccines. So first, we'll talk about standard, like what is on the package recommendations within the US, is that under 15, you're getting 2 doses, at least 6 months apart, although often, because we're not seeing that patient until the next year, you're doing that at 12 months, versus after 15, we are doing 3 doses, 1, the second one a month later, and then that 3rd dose at 6 months plus.
I want to underline that if you can start the series before the 15th birthday, they only need 2 doses. So even if you can get 1 dose in, you don't even have to finish the series. But if they start the series on or after the 15th birthday, it's a 3-dose series. Now that may change in the United States. They are reconstituting the HPV work group for the Advisory Committee on Immunization Practices to look to see if the United States is going to again reduce the number of doses in the series. But that remains to be seen. Currently, the FDA approves it as a 2-dose series if you start the series before the 15th birthday.
If an adolescent is sexually active and potentially HPV positive, will the vaccine be effective? Yes. And do you test for HPV? So I will talk about, we are still, at least based off of current guidelines, starting screening for cervical cancer, which is not HPV specific at 21 years old. It's not until 30 that the recommendation is to do co-testing with both the cells as well, like cytology, as well as HPV. There is no need for any kind of cervical cancer screening prior to that age, regardless of sexual activity. But I think the vaccine recommendation for me feels even more important, knowing that at least the American Cancer Society is actually considering moving that recommendation up to 25. And the big reason for that is because vaccinations has dropped cervical cancer cases so significantly. But my worry is especially when you see even just, I want to say earlier this year, there was a Black woman in her 30s, an influencer who died from cervical cancer that got misdiagnosed and could have been treatable or ultimately avoided with appropriate vaccination. That when there's concerns that we're now screening at later and later ages, the vaccine really is going to be the best protection for making sure that all communities are going to be protected against that. So any opportunity to be able to do so even after exposure is important, but we're not doing that screening, at least for now, until 21. It's to be continued if that may change. All right. Our next, is there an increase in HPV vaccine hesitancy due to the polarization of COVID vaccines?
I would say yes, absolutely. There's so much vaccine hesitancy in the United States. A group from Syracuse, including Joe Domachowski, looked at if you're in a red state versus a blue state by presidential voting, that your likelihood of being vaccinated against HPV goes down if you are in a Republican state. To me, that's worrisome. Just like where you're born shouldn't influence how likely you are to be protected against cancer.
And I think also there's just this general questioning of what, these things were made too quickly, what's in them. And so I think there's often been a lot of highlighting and spotlighting of any type of vaccine that does not have this long history. And so I think a lot of the concerns that came up initially are now often resurfacing in conversations or online and therefore in our exam rooms as well. Next question, what are major adverse reactions to the vaccine? Any differences for age groups?
Well, the main one is pain. This is a vaccine. I think most vaccines hurt. Adolescents complain about things that hurt. I do work for immunize.org. If you have never gone onto this website, immunize.org, I really hope that you do. We have a whole thing on addressing anxiety and pain because I think that we could reduce the vaccine hesitancy if we just did little things like saying, like kids' pediatrician's office, it said we couldn't use a cell phone inside the exam room. Well, if they could have used the cell phone, it could have distracted them during using distraction. Like with little kids, we use bubbles and pinwheels, but with adolescents, we could find distractions like using your cell phone, listening to music, lots of things that are cheap. They have the cell phone in their pocket anyway. So immunize.org has a series of handouts for healthcare providers about how to decrease anxiety and pain. But we also have them designed for parents and for adult patients. My husband is an asthmatic and he, for many years, avoided getting a flu shot despite what I do for a living. And so I finally said, why won't you get your flu shot? And he said, because it will hurt. And so even adults need help managing injection pain.
I think you actually just answered the next one about any administration considerations to reduce pain related to the HPV vaccine. The only thing else I would add is that often, as somebody who sees adolescents all the time, really just trying to appeal to vaccines are going to hurt regardless. And so sometimes there's the 2 versus 3. I'm like, you would rather have sore arms once than having to come back and do this again. And sometimes that can help. But also there's people who it's just a mental game and they're like, hey, I can only do this one, but I will come back and we make plans. All right, here's when you're coming back just to be able to get those other ones in that same short time frame, as opposed to, all right, I'll try to catch you the next time. If we've gotten that, yes, we just have to figure out the logistics to make sure that happens.
There's a genius pharmacist at Sick Kids who has done a lot of work on pain. And one of the things that she says is you use the most painful vaccine last. So if you're going to give TD and HPV at the same visit, do the HPV second.
How would you approach the conversation with parents if the child is open to receiving the HPV vaccine? I would personally not mention the fact that the child expressed interest and instead try to make that be a family decision, just because I would worry about the situation where that child then feels like they can't speak up, or later on the parent's like, well, why did you say that we're doing this? And so I will just say, I actually recommend teenagers to start making decisions of their own. And if this is a vaccine that they're interested in, then this is something that I think could be strongly recommended for them, and exploring that conversation with them as opposed to kind of being like, oh, well, your kid said that they want this shot. Separately, I may tell the kid, like, also, depending on where I'm practicing, this is something you can't have, or, and preparing them for if the possibility that your parent decides this is something you cannot have, we can plan to do this when you are ready at 18, when you're able to make medical decisions of your own, but really trying to just frame it more of like autonomy generally, as opposed to kind of isolating that particular child. I'm proud of them for speaking up, but I also don't want to put them in a position where they still feel very vulnerable for the fact that they may be going against their parents' wishes.
I'm going to take the one about, can HPV be transmitted at birth? And the answer is yes. I mean, I think a few of you are old enough to remember juvenile respiratory papillomatosis. You don't see it anymore. And part of it is the HPV vaccine has been associated with a real decrease in that too. But that was when children, a baby going through an infected birth canal, would be infected with HPV and so get HPV in their oral pharynx and deeper. And so they would grow papillomas in their airway that had to be lasered off recurrently. It was a huge problem. And, and sometimes ended up because that area would get sticky, that the airway would heal closed. And so it was a big problem. This is, again, something that we don't talk about very often because how many people know about juvenile respiratory papillomatosis, but old people do. I mean, we used to see that. I don't think that's one of the things that's around much anymore.
I actually have another one for you. Have you looked at titers in children who were vaccinated at a younger age versus older age?
Yes. So when we say younger and older, it's hard to imagine that there's immune senescence that early in life. But the difference between an 11-year-old and a 17-year-old, like your immune system is already going downhill. Bad news, it gets worse and worse. But that's why you get a higher antibody level if you vaccinate at 11, 12 than if you wait until you're 17, 18. It's because of immune senescence that early in life. The other thing I just want to point out is that there have also been studies. We said this vaccine has been around for 18 years. So we know that the immunity is persistent.
And then I appreciate we have some thoughts from our colleagues in Canada. In Ontario, it's given in school with Menactra and Hep B at grade 7, but I like the idea of it being given at 9. However, it will not be covered if no private insurance, unfortunately.
Probably by giving it at school,
Yes.
You're more likely to get the job done because everybody's going to school.
And I also I was trying to think of trying to balance that with the equitable perspective versus the missed opportunities. I would actually just say, if you're saying your recommendation is 9, then explaining we're talking about this vaccine at 9 now because we know that this is available to you. And this is when I would recommend it. Unfortunately, insurance does not allow me to give it to 11. So I'll keep bringing this up with you. And in that way, it seems like you're starting that same conversation with everybody and just navigating through those barriers, as opposed to you feeling like you're providing care for some people, but not for others. We all recognize and we all live through the fact that there's what we would love to do versus what insurance and other barriers demonstrate for us. But as long as you're communicating that and kind of starting that conversation, that in my head seems to balance out. If a child gets the first vaccine less than 15, but doesn't get the second dose, now they are greater than 15, do they get 2 more doses? I think you answered that one. So no, if you started the series before 15, you only need 1 additional dose whenever you choose to get it. And why is it not mandated for school entry? Is there a movement for this to happen throughout the U.S. instead of the 3 to 4 states that we talked about?
Actually, Texas was a great example where there was a movement to get it as a mandatory vaccine. And what happened was that there was so much pushback around it that now a lot of states don't even want to open that can of worms because it's like inviting anti-vaccine people into legislative meetings because we're afraid that we're going to lose ground. And I think a lot of states are now losing ground in terms of what's required for school.
I think we have covered kind of the last couple questions, which we said at what age can it be offered, 26, but I think people brought up good points about it can be offered up to 45, but I think that should be a conversation and looking into both risk factors for the patient as well as benefits for them and also coverage for that vaccine through insurance, and that it's not treatment and therefore there actually is no treatment. And so that's all the more reason to make sure that we are vaccinating and offering that.
I think that's one of the things that a lot of parents used to say, well, if he gets it, we'll just get the treatment, and there's treatment in the sense of you can do a cone, but you don't want that treatment. And so there is no treatment to get rid of the HPV from the body, unfortunately.
Is it normal to find warts in children who were delivered by C-section to mothers with warts? Should we still vaccinate these children?
I have never heard of a case through transplacental, so I would say no to that. But based not on that I have heard, the answer is no, but just on that I've never heard, the answer is yes. And I've seen a lot about transmission. I've never seen about transplacental. So I'd say no on that one.
Well, great. That was our last question.
I just want to say one more thing, that it's unfortunate that it's called HPV, because I think it sounds so much like HIV. And that I feel like, certainly back in the early 2000s, when the first vaccine first came out, I think a lot of people thought we were talking about HIV. And so they were like, oh, well, my kid doesn't need it because he's not going to get HIV. And so I think it's unfortunate that name is so close.
Yeah. I actually love that, at least when I'm working with Spanish interpreters, because I'm learning Spanish, but I don't have it. They actually say human papillomavirus. So the families are immediately like, yes, I know what that is, and I want that protection. And so it's so interesting when we talk about messaging that, like if we're hearing these kind of quick acronyms and you don't quite catch the middle word, you're like, when we talk about stigma, even more so for that infection. Okay, so our final takeaways are your recommendation matters so much. Starting at 9 up to 26 is recommended. Continue the conversation past that point, although we're not seeing the people those age, but maybe people in your life who still need that protection, and thinking of all our ways to be able to overcome some of the barriers.
Thank you to Drs. Fenton and Humiston, and many thanks to you, our listeners, for joining in. As a reminder, to view the full program, please click the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you, and we'll see you on the next podcast soon.